I have an initial question. Do you apply the ointment, the dermatologic ointment, on the eyelid? Yes, not inside the eye.
Because it is a dermatologic ointment. They are not eye ointment.
Yes.
So I need, because it's a dermatologic eye ointment, so I cannot apply it on the eye.
Yes, yeah, I see. Really, we have had some experience using dermatologic ointment also for some cases. We used it some years ago, but with the lower concentration, 0.03%.
Oh, okay.
And we on that time we read an article from some researchers, I think from the United States, and we use that ointment in the eye, but some patients do not tolerate.
Yes.
But it seems to work. But now the difference is that you used the higher concentration.
Yes.
And it seems to be very good. The tolerance is very good in that way of use. Yes, on the eyelid.
Yes, tolerance is no problem. But if the ointment going to the conjunctiva sac or the corneal surface, the patient will feel some irritation and some burning sensation.
Yes.
So they don't like the ointment coming to the conjunctiva sac or corneal surface. Actually, I'm going to talk about another regimen. If the tacrolimus ointment does not work, actually in the end, I will show 3 patients. For my own patient, they actually initially they have a very good response to the tacrolimus ointment, but eventually, because this is the ointment, we cannot stop the recurrence. So I changed my regimen in my talk. So I did not show it in my title.
Perfect. Okay, and now we have a topical preparation of eye drops, tacrolimus eye drops, 0.03%, but the tolerance is not very good.
Yes, we have some experience, but because in Taiwan we do not have the eye drop. The eye drop just only can be available in the Japan and the mainland China. So we don't have that eye drop. So we just only can use this dermatological ointment for our patient. That's why we use this ointment. But I think for some cases it is useful. It may be useful for this patient. But the recurrence is still a problem for my patient.
Okay. Okay, good morning, everybody. Today we have the pleasure of having Dr. Ion Wang from Taiwan. Dr. Galvis, who is the director of our institution, is also with us. Dr. Wang.
Good morning. How are you?
Good morning, everyone.
It's a pleasure to have you here with us. Go ahead, yes. Alejandro.
And Dr. Wang is in Taiwan, and he is going to talk about the use of tacrolimus dermatologic ointment in vernal queratoconjuntivitis, severe cases, and at a higher concentration, I mean 0.1%. So Dr. Wang, welcome, and thank you again for accepting our invitation.
You're welcome. I'm very happy and very honored to be here to share my experience. Today, my talk is based on our previous publication in Graves Archive Clinical Experimental Ophthalmology in 2019.
In this paper, we present 10 patients diagnosed with severe vernal queratoconjuntivitis and refractory to the steroid treatment. All the patients received 0.1% dermatologic topical tacrolimus treatment on their eyelid once or twice daily. This picture shows all the 10 patients with severe vernal conjunctivitis. All of them receive 0.1% tacrolimus dermatologic ointment on their eyelid. You can see all the patients improve after the tacrolimus dermatologic ointment on their eyelid. Today, I'm going to talk about another 3 cases, which is difficult to be treated with topical steroid or systemic steroid. Even they were very difficult to be treated with topical tacrolimus dermatologic ointment. So in the first case is a 10 years and 11 months old boy. In this case have allergic rhinitis and atopic dermatitis, and his best visual corrective acuity was not very good. In the initial presentation, you can see the right eye have a very typical seal ulcer in the upper part of the cornea. In the left eye, you can see a very typical keratinization of the corneal epithelium in the upper part of the cornea, which is maybe damaged by the giant papilla from the upper tarsal conjunctiva or the chemical release from the tarsal conjunctiva. So we started to use the topical betamethasone eye drops and the topical tacrolimus dermatological ointment for his both eyes, upper eyelid and lower eyelid. This is a picture 3 weeks after treatment. You can see the vernal seal ulcer still present. However, the left eye shows a very clear cornea after treatment. Unfortunately, the seal ulcer become a calcium plaque 3 months after the treatment. And the 4 months treatment, after 4 months treatment, the calcium plaque did not dislodge from their corneal surface, and the corneal opacity residual in the center part of cornea. And this is 7 months later. You can see there's a residual corneal opacity in the right eye or right eye central cornea. You can see the giant papilla become flat, and the discharge were very little, and the congestion disappear after the treatment. This is 10 months later. You can see the picture is very silent after the treatment. This is 14 months after the treatment. You can right eye is a very still residual corneal opacity, and the giant papilla become more and more flatter. And the left eye, the cornea is very clear, and the papilla is not very large. However, his vernal conjunctivitis reattack again. You can see the right eye show a very typical giant papilla and with mucoid discharge, and the corneal epithelium was damaged by the giant papilla, even by the chemical release from giant papilla or pressure damage from the giant papilla. In the left eye, you can see the giant papilla reappear again, and the mucoid charge also appear again, and the corneal epithelium was damaged by the papilla, even by the chemical release from the papilla or the pressure from the papilla. 1 month later, you can see the seal ulcer reappear again in the left upper part cornea, and the giant papilla also reappear again. The discharge was not so severe. 3 months later, you can see the right eye, the giant papilla still present, was but the discharge become less, and the cornea become more stable after we use the topical betamethasone eye drop and the topical dermatological tacrolimus ointment. In the left eye, you can see a progress of severe ulcer in the upper part of the left eye cornea. You can see the giant papules are present. And 5 months later, you can see the right eye become still have the giant papilla, and the cornea epithelium was very smooth, and the central corneal opacity is still over there. However, you can see the calcium plaque appear in the area of previous severe ulcer, and giant papilla become more severe, and the mucosa increase 1 month after the treatment. So we consult the pediatric immunologist. They suggested use the intramuscular omalizumab 150 mg every month for 6 to 8 times. And the patient's father and parents accept this treatment. So he started to be used the intramuscular omalizumab. You can see the skin very typical atopic dermatitis. This is a picture for his left eye also. This is the upper part tarsal-conjunctiva. 1 month later after treatment, you can see the calcium part increase after treatment. A giant papilla is still present, and the mucosa become less after treatment. We still use the topical betamethasone eye drop and the topical tacrolimus dermatological ointment concomitant with use systemic intramuscular omalizumab. This is the right eye. You can see 1 month after treatment, the mucoid discharge is still present, and the corneal surface is not so rough and still very smooth after treatment for his right eye. However, you can see the giant papilla become less. This is after the use 1.5 years use of intramuscular omalizumab. The condition become very stable after treatment, and this is 1.5 years later. Left eye show a very stable corneal condition, but still a corneal opacity over there. But you can see the corneal inflammation, the conjunctival inflammation become less, even very silent. However, you can see a residual corneal opacity as some calcium plaque deposit in the upper part of the right cornea. But you can see the conjunctiva is become less congestion and become very silent. However, 5 years and 5 months later, you can see vernal queratoconjuntivitis reattack in the right eye. You can see a residual corneal opacity and a calcium plaque deposit in the upper part of the cornea. And you can see the conjunctiva discharge still present. So we consult a pediatric immunologist again. They restarted use the intramuscular omalizumab again for 6 times or 8 times for this patient. You can see the cornea become very, very stable. You can see the upper tarsal conjunctiva become maybe a little bit fibrosis, but no giant papilla in the upper part tarsal conjunctiva in his left eye. In the right eye, you can see a residual corneal opacity, and the conjunctiva become very silent. The upper tarsal conjunctiva, you can see a giant papilla disappear, and a very little bit fibrosis in the upper part tarsal conjunctiva. This is the left eye again. For the case 2, is a 9-year and 9 months old girl. He also have a topical dermatitis, asthma, and allergic rhinitis. In the initial presentation, you can see a very terrible tarsal conjunctiva, upper tarsal conjunctiva. The cornea epithelium was damaged by the upper tarsal conjunctiva in the right eye because it very central corneal opacity and the cornea epithelium damaged by the upper tarsal conjunctiva. In the left eye, you can see also a very typical upper tarsal conjunctiva, giant papilla. I can see lower part shear ulcer in the left eye. You can see lower part of tarsal conjunctiva did not have a giant papilla. So in this case, we started use the topical betamethasone one times or twice per day, and we also apply the topical tacrolimus dermatological ointment for the upper and the lower eyelid once and twice per day. After one week later, you can see the upper tarsal conjunctiva become not so huge, and the conjunctiva inflammation become less, and you can see the corneal opacity over there. But the corneal epithelial damage was not disappear again. Just 1 week after use our topical regimen. However, in the left eye, you can see the giant papilla still present, and the mucoid discharge is very severe, and the upper partial ulcer combined with the lower partial ulcer appear in the left eye cornea. 2 weeks later, the right eye corneal condition and the tarsal conjunctiva condition become very stable. And the left eye, you can see the discharge become less, and the giant papilla become not so severe, and the calcium plaque appear again after evolution of the shear ulcer in the upper part of the cornea and the lower part of the cornea in the left eye. 3 weeks later after treatment, you can see the right eye corneal condition and the tarsal conjunctiva condition become still stable. However, in the left eye corneal condition, you can see that the upper part shear ulcer disappear again, but a residual corneal opacity in the upper part of the cornea. In the lower part cornea, you can see a calcium plaque deposit over there. However, you can see a very huge and a very terrible tarsal conjunctiva appear in the upper tarsal conjunctiva and the mucoid discharge over there. However, in 4 weeks later, after treated with a topical regimen, you can see the corneal condition become increase severity. You can see corneal epithelium was damaged by the upper tarsal conjunctiva, and you can see the corneal damage is very diffuse. Also, you can see the upper tarsal conjunctiva increase the severity, and the mucoid discharge appear again. In the left eye, the condition is almost the same with the cornea and the tarsal conjunctiva condition in the 3 weeks after treatment. In the 5 weeks later, you can see we continue use our regimen. You can see the corneal condition become more stable, and the tarsal conjunctiva become the giant papilla in the tarsal conjunctiva become not so huge, and the discharge become less. In the left eye corneal condition, as you can see, the corneal damage was not become decreased after our regimen. As the calcium plaque still in the lower part of the cornea, and the upper tarsal conjunctiva still over there are still very huge, and the mucoid discharge still over there. This is 6 weeks later. You can see the right eye, the condition has become very stable. Left eye, the condition is also stable, but still not so good. Because her left eye condition, so we consult pediatric immunologist again. The pediatric immunologist started to use the intramuscular dupilumab, 300 milligram every 3 weeks and for 6 times. This is a right eye condition in the initial treatment of the intramuscular dupilumab. And in the meantime, we still continue use the topical betamethasone eye drop once or twice per day, and also use the topical dermatologic Tacrolimus ointment. This is a left eye condition in the beginning treatment of intramuscular dupilumab. So this is a six weeks later. You can see the right eye. You can see the conjunctiva, upper tarsal conjunctiva. You can see the giant papilla disappear after you use the intramuscular dupilumab. As you can see, the corneal condition is very stable. It's very dramatic change after use this intramuscular dupilumab. You can see the upper tarsal conjunctiva, the giant papilla become smaller. The corneal condition become very stable after use these biologics. This 7 weeks later, no, 16 weeks after initial presentation, the right eye condition. You can see that the upper tarsal conjunctiva even actually disappear after use the ipilimumab. You can see the left eye upper tarsal conjunctiva. You can see the giant papilla become very smaller. However, the protrusion of the upper tarsal conjunctiva is still present. But you can see the corneal condition is very stable. You have a residual opacity over the left eye cornea for this patient. This is 20 weeks after for the right eye. You can see the right eye condition is very, very stable. It's a very dramatic change of the left eye upper tarsal conjunctiva. You can see the giant papilla disappear. Maybe a very small papilla over there. The corneal condition become very, very stable. This is 24 weeks later for the right eye. Very stable and very normal upper tarsal conjunctiva, residual corneal opacity for her right eye cornea. This is a left eye condition, still very small papilla over there, but corneal condition also very stable. For the case 3 is a 14 years and 7 months old boy. He suffered from the topical dermatitis, also with vernal queratoconjuntivitis. In the initial presentation, you can see the right eye a very severe calcium plaque in the right eye cornea. You can see the upper tarsal conjunctiva very typical, not so huge giant papilla. In the lower tarsal conjunctiva, there's no papilla over there, and there's still some mucoid discharge between the giant papilla. You can see 1 month the left eye condition is more stable than the right eye. The giant papilla, the papilla is not so huge, as a very little mucoid discharge between the papilla can be found. 1 month after topical treatment with the topical steroid eye drop only, you can see conjunctival inflammation become not so severe and become a little bit improve after treatment. However, a residual corneal opacity in the center part of the cornea and the calcium plaque over there, and the giant papilla still over there, and the mucoid discharge can also be found in between the giant papilla in the right eye upper tarsal conjunctiva. In the left eye, you can see the tarsal conjunctiva condition and the corneal condition were stable 1 month after treatment. 2 months 2 months later, after treatment with the topical steroid only, you can see the calcium plus still over there, and the corneal opacity still over there, mucoid discharge still present, and the giant papilla still over there. The conjunctiva inflammation become improved, but still have some inflammation over there. The left eye condition is still very stable. 3 months later, you can see the calcium plus and giant papilla still present, and the mucoid discharge still present. The papilla become smaller after treatment, a little bit. The left eye condition is almost the same. And the calcium plus discharge from the center part, the cornea surface, 4 months later, you can see giant papilla become less, and the mucoid discharge is still over there, but not so much. And the left eye condition is still very stable. 5 months later, you can see almost the same with the condition in the 4 months. 5 months and 2 weeks later, the condition is improved a little bit in the right eye. However, 2 weeks later, you can see a shear ulcer appear in the left eye upper part cornea. Even at this time, you can see the papilla is not so large. However, the mucoid charge increased very much at this moment. Right in the 6 months later, after use the topical steroid only, you can see a residual corneal opacity in the center part of cornea. Actually, the corneal condition improved very much at this time. Calcium plus still over there. The giant papilla become less, and the mucoid discharge become less a little bit in the right eye. In the left eye, the shear ulcer still present over there. The giant papilla become increased a little bit, and mucoid discharge is still over there. And in the 7 months after use the topical steroid only, you can see the shear ulcer become a residual corneal opacity. The papilla, you can see the upper tarsal papilla become less, and the discharge decrease after using the topical steroid only. And this is right eye. You can see the calcium plus dislodge from the cornea surface, a residual corneal opacity in the center part of the cornea. The upper part, you can see upper tarsal conjunctiva. You can see the giant papilla become smaller and the discharge become less after using topical steroid only. However, the 8 months after initial presentation, the shear ulcer reappear again in the center part of the cornea in the right eye. So we put on the topical dermatological tacrolimus ointment for his upper and lower eyelids, in addition to the topical betamethasone eye drop once and twice per day. This is the right eye condition at that time. So 1 month later, you can see the inflammation become less, and the calcium plus also become less after we added the topical dermatological tacrolimus ointment. This is half years later after we use this regimen. You can see that right eye, there's a residual corneal opacity in the right eye cornea. However, you can see the upper tarsal conjunctiva. You can see giant papilla still over there, and the mucoid discharge still over there. This is the upper tarsal conjunctiva. For his left eye, you can see half years later after we put on the topical dermatological tacrolimus ointment, you can see the cornea become reattack again. The corneal condition become to reattack again. It means that the shear ulcer will reappear again. You can see that the corneal epithelium was damaged by the upper tarsal conjunctiva giant papilla at this time. You can see this is his left eye upper tarsal conjunctiva. A giant papilla reappear again, and the mucoid discharge can be found very huge, very much between the giant papilla. 1 month later, you can see the left eye cornea condition is almost the same with the last 1 month. And you can see the upper tarsal conjunctiva giant papilla and mucoid discharge is almost the same with the last 1 month. You can see the right eye cornea condition. You can see the cornea condition almost the same with the last 1 month, also for the right eye. So we started to use because the cornea condition and the conjunctival condition did not improve after our regimen. We started to put on consult the pediatric immunologist. They started to use the omalizumab for 6 times every 4 weeks. And you can see that this is a picture. In the beginning, we used omalizumab. The cornea condition, the upper tarsal conjunctiva, the giant papilla is over there, a mucoid discharge over there. Cornea condition, cornea epithelium was damaged by the giant papilla at this presentation. So 3 weeks later, after we using the omalizumab, this is the right eye condition. You can see the giant papilla still over there. A mucoid discharge is still present, and the cornea condition did not improve after we put on the omalizumab. Even a very small shell appear in the center part of the cornea. This is the right condition. You can see giant papilla over there. So I mean 3 weeks after 3 weeks using the initial 1 dose of the omalizumab, the left eye cornea condition and upper tarsal conjunctiva conditions still did not change after we used the omalizumab. However, 2 years later, you can see in the right eye, the upper tarsal conjunctiva, you can see the giant papilla disappear. It become even you can see a very little bit of fibrosis in the upper tarsal conjunctiva. The cornea condition in the right eye is very, very stable. No calcium plaque, no shear other reappear again. Residual corneal opacity in the central part of cornea and the lower part of the cornea. For the left eye, the condition is almost the same in the right eye, because you can see the upper tarsal giant papilla disappear again, and no mucoid discharge was found. You can see the corneal opacity corneal condition is very stable. The residual corneal opacity over there, no corneal epithelial damage after we use omalizumab. So this patient is very stable till now. So no recurrence of the vernal keratoconjunctivitis after we use the omalizumab. Is it right? So for the treatment of a refractory vernal keratoconjunctivitis, we have many choices. The first choice also we know that the topical steroid. However, the side effect of topical steroid make us very hesitate to use for this case. We can switch to the topical cyclosporine. We also can switch to the topical tacrolimus. We can use topical cyclosporine in different concentration. However, for this concentration, we need a very higher concentration. For example, the 2% of topical cyclosporine for this severe vernal keratoconjunctivitis. So in Taiwan, we don't have a topical tacrolimus eye drop. We just only have the topical dermatological tacrolimus ointment for topical dermatitis. So many years ago, we consider that the topical dermatological tacrolimus ointment may be useful for this patient, because this patient have topical dermatitis, also have a very severe vernal queratoconjuntivitis. This is the mechanism we don't need to mention too much. And actually, the topical tacrolimus, the main action of the tacrolimus is that this chemical can inhibit, reduce IL-3 and IL-4 and TNF-alpha secretion by basophil, eosinophil, and the macrophage. However, the problem is there any possibility for the topical tacrolimus dermatological ointment can penetrate through the skin and the muscle to the conjunctiva? Is it possible? We think it is possible because in this patient, suffer from the atopic dermatitis, though they have a defect in the skin barrier, and this tacrolimus molecule is a lipophilic molecule, so they can penetrate to the skin. So we also use a more higher concentration. We use a top 1.1% tacrolimus ointment because this condition is more higher. They can penetrate to the cornea, to the skin, muscle, and to the conjunctiva. I think the possibility is more higher than the low concentration. And also, we think that it is maybe possible to have a localized diffusion from the blood vessel after we use the topical dermatological ointment. So we think that it is possible to use this regimen to treat the vernal queratoconjunctivitis through the skin barrier. However, the limitation is this is off-label use, and this is still recurrence with some after we discontinue or taper the medication, and the long-term effect and the side effect is still not known at present. And there's an available osmotic or tacrolimus suspension ointment in Taiwan, so we use this off-label use regimen. So you can see even we use topical tacrolimus eye drop or the dermatologic ointment. Actually, these patients still have the opportunity or the chance to reoccur again because they are topical use only. So we must think that we must use biologics such as omalizumab, dupilumab for this patient. So actually, both agents are the target of this monoclonal antibody are the IL-4. It means the IL-4 is secreted by the B cell. Actually, I don't know the logics which one is preferred by the pediatric immunologist. I didn't ask why they choose omalizumab or dupilumab. But both agents are very effective to prevent the recurrence of this vernal queratoconjunctivitis.
Dr. Wang, very interesting presentation. Thank you.
You're welcome.
Alejandro, I would like to make some comments about the lecture. Perfect. It's a nice lecture, Dr. John. But in our hands, when we have very severe cases of vernal or we have a systemic atopias, we use systemic tacrolimus 2. The name in Colombia is Prograf. The pills come within 0.5 milligrams per day, and we make surgery in that cases, and we remove the conjunctival papillae in surgery, and we infiltrate subconjunctival dexamethasone in that patient. And when we want to improve the scar, we use sometimes in the drop insulin, 60 or 40 or 60 unit, and the scar improved rapidly, and the ulcus decreased in time a lot. This is our perception in that cases, and we used to the tacrolimus, and the power of tacrolimus and acceptability of the drugs versus cyclosporine is much better. That's my comment.
Thank you for your comment.
Yeah, Dr. Wang, very challenging cases that you have shown, very difficult cases. And,
yes, I'm so sorry. Because I have some comment about conjunctiva resection. I mean, in the maybe 20 years or 30 years ago, we also did the papillectomy. Jam papilla, we remove the jam papilla or some conjunctiva for these severe cases. But for these cases, eventually 20 years later, actually they have a very tight eyelid. Some cases develop, even some cases develop glaucoma for this patient. So I'm so afraid to do the papillectomy or conjunctiva resection for these severe cases of vernal conjunctivitis. In Taiwan, we also have the systemic tacrolimus. Okay, but we cannot use the tacrolimus because of our insurance policy. Because our insurance did not cover this, the tacrolimus for these children.
Okay, I see. And Dr. Wang, okay, but usually these are very, as I was commenting, these are very severe cases. But in the higher percentage of vernal queratoconjuntivitis cases are not so severe. Your step are in first you begin with topical steroids cycle, and then topical dermatologic tacrolimus ointment.
Actually, in Taiwan, we actually most of cases are started to use topical steroid in the beginning for every cases. But you can see it's very difficult to adjust the doses of the steroid, even the topical steroid, because the steroid glaucoma or cataract formation, and sometimes this case develop corneal ulcer after the use of topical steroid. So it's very challenging for this case. So for most of our corneal specialists, prefer to use non-steroid preparation. Okay, this is but we do not have too many choice. I imported some topical tacrolimus eye drop from the mainland China and then Japan. It's very expensive for this eye drop. So, but for this case, even they use topical tacrolimus eye drop, they still have some recurrence after use, because it's just only a topical medication preparation for this case. I think because eventually I always maybe all of the severe cases like the case I presented today, I strongly suggest they use biologic to prevent their recurrence. Actually, the effect is very good for this case. So for these three cases, they do not develop recurrence after we use the topical biologics. So in the beginning, I think this for some cases, because in my paper, we presented 10 cases. In these 10 cases, almost 8 cases do not occur again. I think the topical preparation is enough. But for the severe cases, I need the biologics.
The biologics. And for how, how long time is the maximum that you have used topical dermatologic tacrolimus in the cases that are responding, that have a good response? Do you extend the tacrolimus ointment for months?
Yes, because the ointments still need to penetrate to the skin and muscle to the conjunctiva. So I think the time is we need 2 weeks to 1 month to have to have an improvement of the treatment. Okay, so not but you can see sometimes we use steroids still has some effect. For most of the cases, you can use steroid as a condition will improve a little bit, but some recurs very quickly. But for use a topical tacrolimus, recur actually they can recur. They also can recur once per year in my cases. Okay, but for the biologics, till now they do not have a recurrence right now.
So now you are using the biologics much more frequently than before.
For the severe cases.
For the severe cases. And what about your long-term experience with ointment of tacrolimus? I mean, it's not a problem to repeat the cycle of ointment of tacrolimus several times and keep the patient with tacrolimus ointment for, let's say, 6 months, 1 year?
Actually, because I use the ointment twice per day, before sleep and after waking up. Okay, and when they wake up, they put the ointment, and before they sleep, they put on the ointment. On the upper eyelid is more important than the lower eyelid because the papilla is on the upper tarsal conjunctiva. So I think the compliance and the tolerance is very good for these children. But I think I still need the parent to apply the ointment for some very small children. But for this case, they use the topical ointment for 2 or 3 months. And I switched to the once per day 3 months later. As I keep the once per day for almost 3 months, another 3 months. Then I will discontinue to use the ointment.
Okay, thank you, Dr. Wang. Thanks a lot for sharing with us your experience and your knowledge in this very interesting field with very difficult cases. And I think that we have learned a lot from your lecture, and we will be in contact about our experience with the biologics, and we will explore, and with the 0.1% use of tacrolimus in these cases. So, Dr. Wang, thank you again.
Thank you for your invitation. Thank you very much. Bye-bye.
A very good night for you.
Bye-bye.
Bye-bye. Thank you again.